Hi, this is Joe Chaffin, and this is Blood Bank Guy Essentials, episode 082. We're going to forgo the intro music today simply because I'm coming to you with kind of an emergency podcast, I guess I would say. Most of you, I think, are aware that this is not usually what I would call a topical podcast. In other words, I don't usually take on the current events of the day. It's meant to be educational. That's what I do. But there's so much going on right now with the coronavirus, specifically the SARS-CoV-2 virus that causes the disease called COVID-19. And I've had a lot of questions from many of you regarding your concerns, your fears, quite frankly, and what's going to happen with the blood supply. What are we going to do with this? In fact, as I sit here right now, I am staring at my computer at the very excellent Johns Hopkins University coronavirus site, and it is showing, and I'm recording this at 9:40 p.m. on the west coast of the United States in California on March 16, 2020. And this map shows 182,406 confirmed cases worldwide with 7,154 deaths. And that's really, really scary. In fact, when you look at it and break it down a little further, you see that there's over 81,000 cases in China with 3,200 deaths, over 28,000 cases in Italy with 2,150 deaths. And at this moment in the United States, we have 4,661 confirmed cases with 85 deaths. Obviously, things look a little different right now in the United States than they do in other places. But I think we all recognize that we are on the upward curve here in the United States, and the rest of the world has been dealing with this for a little bit longer than we have. So I want to take this opportunity today to talk with Dr. Louis Katz about the coronavirus. Dr. Katz, who you may have heard speak if you've been to AABB meetings or in any number of webinars and seminars over the years. Louis is the Chief Medical Officer at Mississippi Valley Regional Blood Center in Davenport, Iowa. He's also the chair of the AABB Transfusion Transmitted Diseases Committee. Louis is not only a board-certified internal medicine doc, he's an infectious disease specialist, and he has a long background in infectious diseases, including back to the early days of HIV. He has done enormous work in transfusion transmitted diseases in his transfusion medicine career. When I talked with Louis earlier today, we just really kind of wanted to focus on what is important for us in the blood bank world. This is not the podcast for you to hear all about COVID-19 or for you to hear all about the SARS-CoV-2 virus. We'll talk a little bit about that, but mostly what we're focusing on is two main things. Number one, what is the deal with this in blood centers and what should we be doing now? And further, what should transfusion services be doing? And a little bit at the end, we'll talk about some of the things that many of you have asked me about, such as convalescent plasma and its role in the treatment of patients with COVID-19. So I don't want to hold you up anymore. I want to give you right now my interview from today, March 16, 2020, with Dr. Lou Katz on COVID-19 and the blood supply. Hey, Louis, thank you so much for joining me. I appreciate it, man.
Yeah, my pleasure, sorta.
These are interesting and challenging times, and I want to take some time with you this morning to just kind of get into this. I want to tell everybody up front, I am recording this with Dr. Katz on March the 16th. I plan on putting this episode out March 17, which pretty much guarantees that by March 18 or 19, everything we say will be out of date and will look silly. But the idea is to kind of address things as much as we can right now. There's a lot of concern, a lot of questions out there. I don't want to take the time, Louis, to go into enormous detail about what the virus is and all that. People can find that elsewhere. But I think if we could start with just a real quick terminology clarification. I hear people using the phrase, the term COVID-19 to refer to the virus, and then other people talk about SARS-CoV-2. Can you just clarify that? What's the difference between that, SARS-CoV-2 and COVID-19?
Well, there's a little bit of conflict between WHO and one of the big taxonomy groups about what's what, but it's not complicated. So SARS-CoV-2 is the name of the virus, and COVID-19 is the name of the illness caused by SARS-CoV-2. Do we need both? I don't know, but we have both, and I'm pretty good, because this is what I do for a living, at using the right term at the right time. But I know what you mean if you say COVID-19.
And I think probably most people do too. So
Yeah.
that's just my compulsive blood banker nature coming out there for a second.
You must have an SBB in addition to an MD.
Something. Okay, Louis. So in my blood banking career, and I've been around for a while, certainly as not that you're old or anything, my friend, but I'm just saying we've both been around for a while. Since the year 2000, we've seen, I believe, correct me if I'm wrong, that this is the third coronavirus episode that we've been very concerned about. 2003, or 2002, 2003 was SARS, severe acute respiratory syndrome, then Middle East respiratory syndrome, or MERS, in 2012. And this one now obviously starting in 2019 and blossoming in 2020. Can you talk a little bit about the differences between those three? And the similarities, maybe.
Yeah, there are three different viruses. They're all beta coronaviruses, but it's not hard to get them on the same phylogenetic tree, but so they are cousins, but they're not siblings. And the new virus is most closely related to a bat coronavirus, not to the SARS virus. And then MERS-CoV is it's a different virus. It causes a different disease with different epidemiologic characteristics, and probably importantly, uses a different receptor to infect cells. So I think most of us are looking at the SARS experience to see if there are precedents that are relevant to this new virus. But basically, we have to gather the data ourselves. It's a different virus. It's behaving somewhat differently, and we need to pay attention.
Absolutely. So one quick question, because I saw something over the weekend, Louis, that surprised me a little bit, given the current level of obviously major concern about this. Is it correct that both SARS and MERS had, at least to date, higher in individual case mortality numbers than SARS-CoV appears to?
Much higher.
Okay.
I mean, ongoing MERS has mortality between 30 and 35%. Wow. It's highly lethal, but it hasn't spread the way that SARS did, and certainly not the way that SARS-CoV-2 has spread. So MERS has stayed confined to the Middle East, primarily the Arabian Peninsula, with one outbreak tied to the Middle East in Korea. And that's where it sits, and it's now endemic, and it sits there, and it does its badness. The SARS virus, the original SARS virus, at least in terms of human populations, has appeared to have gone extinct. I presume it still lives in bats somewhere. But in terms of human infections, there have been none since the original control of the epidemic. And SARS was 8,000 cases with a 10% mortality rate. SARS-CoV, we're now we'll be at 200,000 cases this week, I suspect. The mortality rate is much lower, but because there's so many more infections occurring, it is so much more widespread in terms of the pandemic that the number of deaths will far exceed that from SARS. We have a problem in that we don't know. We're not counting cases for the denominator in that mortality rate accurately yet. And we won't until we have a good antibody test, and that's weeks and months away. So we're accessing the worst cases, and we're talking about mortality rates of 2 to 3 or 3.5% for SARS-CoV-2. I think that will prove to be way too high, and people are now talking about around 1%. So for context, 1918 influenza was 1 to 3%, so it's in that range. A standard seasonal flu is 0.1%. So the new virus is looking like, and these are very rough numbers, and they will change. So anybody quotes me, I'll come after. Maybe, in the range of 10 times more lethal than a standard seasonal flu. That said, almost 40 million cases of influenza A in the U.S. this season. And last count I saw, it's a week-old information, was 16,000 deaths. So get your flu shot.
Right. Right. Absolutely. Okay. Well, so again, I don't want to take
the time to go into great depth about the actual disease itself. I think we all know that this is that there are particular groups that are at greater risk, older folks, people with chronic diseases, and that this is especially a significant issue in the lungs. Again, I know there's discussion about other organs being involved, but lungs are the big deal. But maybe we could talk a couple things, Louis, real quickly about first, what we know so far about how this appears to be transmitted, and second, whether transfusion is likely or not likely to be a part of that.
Yeah. One comment about age. One comment.
Please.
That is that Tony Fauci yesterday told me that I should stay home. I'm old enough. So there is that.
Yes.
So this is a coronavirus. And like this is the 7th coronavirus that infects humans. The other 6 are all spread by droplet. That's the big chunks when somebody coughs or sneezes, right?
Right.
And contact. And contact because the big chunks land in the environment, and the virus can survive long enough for you to pick it up on your hands and inoculate it into your eye, nose, or mouth. So droplet and contact, as opposed to airborne like TB and measles, which is a totally different thing. So droplet and contact precautions are what are being recommended by public health, both WHO and CDC. And people can look that up online and get the details. But primarily droplet, also contact. Is it a TTI? Well, never say never, but no, I believe not. And I believe there's consensus that the risk from transfusion is what the lawyers would call de minimis. Really so low that we need to spend our time talking about other more important things in the face of a pandemic. There is no precedent for transfusion transmission of a coronavirus. Neither MERS nor SARS-1 have been even alleged to have been transmitted by blood transfusion, and we suspect that this will be the same. We need more data, and we need to look for it and all that. The reason people have been concerned is just like SARS and just like MERS-CoV, if you look for the genetic material of the virus in blood and plasma, you can find it in a proportion of cases. But that's fragments of genetic material, has never been shown to represent infectious virus for the other two. And I suspect that precedent is appropriate to consider here. And we're really downplaying the risk that it's a TTD.
Got it. Okay.
Is that brief enough for you?
That's great. Well, let's spend the rest of our time together, Louis, talking about a couple of things that I think are very important. And the first of those is problems with collection and blood supply. And there's a couple of aspects to that, certainly. So I guess my first question to you is, what do you see in your many roles, but including your role as chair of the AABB TTD committee? What are you seeing as problems that blood centers are facing right now as a result of this?
Well, so at my center in the upper Midwest, 4 states, 200,000 whole bloods a year, we have about 1,000 donations canceled between now and mid-April. Okay, so 200,000 a year, a month, we're losing 1,000. That is not trivial, and we're only at the beginning. As I talk to my colleagues elsewhere, similar patterns, a little worse here, a little less bad there. If you look at pictures from China, from Wuhan, early on, their donor rooms were emptied, as were the streets and the restaurant, and everything was emptied in Hubei province and Wuhan. So the worst case scenario is this is very difficult, and both at the local, regional, and national level, we're asking public health to support us. Medical care requires blood, and somebody with acute leukemia can't postpone safely their treatment. People continue to get hit by cars and other reasons for trauma. Urgent surgery has to go on, so we need blood. It may be that we'll need a little less, but we're going to need a lot.
Right.
And so we're working with the powers that be all the way up the food chain to D.C. to get a message out that donors need to keep donating. And that can be a complicated message, obviously, because of all these issues of what constitutes social distancing.
And I think that's both of those are important, Louis. So I want to attack that from two sides. First, there's of course, the question of what do you say to donors to kind of try and reassure them of their safety. But there's also, again, you and I are both in this environment, and I think it would be naive of us not to just put credence to the fact that some of our staff are concerned. How are we protecting them from the quote unquote asymptomatic donor?
Absolutely. It's an important question. So first of all, let's start with an overarching premise that I've been pushing to CDC quite hard the last several days. It is my opinion, and as an ID doc and public health officer, that one of the safest places in the community is a blood drive or a collection facility donor room. And the reason for that is that, number one, all our experienced donors know they have to be well to donate, and that's 80%. And then the other 20%, some are lapsed donors, some are first time, are told that when they're recruited. So we're immediately taking as many people who have respiratory symptoms out of the potential donor population and asking them not to come to the collection site. When they get here, the first thing they see is that message. If you have these symptoms or have been in contact with, don't donate today, come back when everything settles down. So we're taking a substantial portion of the risk that exists in the general population out of the donor population, out of our blood drives, out of our donor rooms. I told somebody from the media yesterday that if I was looking for a safe place to sleep in the midst of the pandemic, I might want to camp out in my donor room.
That's fantastic.
Well, I'm trying to get the CDC to say that, but they won't.
Probably not in those words.
Not in those words. Anyway, so that's critical, and our staff needs to know that.
Right.
We must not confuse collection operations with acute care facilities. We are not. We are subject at the outset to recommendations for the general public.
Right.
And then we add on top of that the measures that I've described to you that really should markedly reduce the risk. And then we're looking very carefully at our environmental disinfection, how we physically set up drives to make sure that we have people as far apart as possible. All those things are happening on the fly, rapidly, and being done. So donor rooms are safe.
Yeah. Okay. And I'm assuming that exact same message is what you're saying to your staff. And you know, I mean, one of the things that I keep hearing about, and I know this is somewhat controversial, and I don't know how much you'll want to go into this, but the issue of putting staff into stronger personal protective equipment protection than they are now. How do you feel about that?
I actually have an opinion, and I know that will surprise you.
It is shocking.
Yeah. So, first of all, and the weakest of my arguments, there are really two. The weakest argument, but still valuable, is that masks have not been shown, masks on well people in the general public setting have not been shown to have a material impact on transmission of anything. Most of the data comes from flu, and it just suggests they're not very effective for wide varieties of reasons having to do with whether they're used correctly, how long they're used for, other routes of transmission like contact and that sort of thing that occur. So we don't think they're terribly effective, but the critical issue, and this is really important from a public health standpoint, is that there's a shortage of masks, and they work well in acute care settings where, in fact, you're dealing with patients with the disease that you're talking about.
Mm-hmm.
We need them for staff in acute care facilities and not to be used in low-risk public venues. And I think it's our responsibility to discourage the use of masks in the donor room specifically, but in the general public. Masks are on back order, and people who are taking care of people, getting right in their faces to deliver acute care in hospitals and ICUs need those masks.
I could not agree more with that. Hey, I found myself agreeing with you, Louis. What's the deal? I'm a little confused. All right. Well, so I think those are hugely important questions. The second set of questions that I'm getting, and I know you are as well, is what about the hospital setting? What should hospitals be doing, in your opinion, to consider things in regards to their blood inventories or transfusion practices or things like that?
Yeah, we're having that conversation with our hospitals. And, if there's a silver lining to the flu pandemic in 2009, it's that we all wrote pandemic plans, including templates for triage of blood products when they get short. So we have dusted those off, literally, and read them and reviewed them, made a few edits, done a find and replace so we could take out flu and put in COVID-19 and sent them out to our hospitals. And now we're following up by saying, what are you doing? You need to plan for the worst, and that includes triage of blood products. And we need to know what your triage plans are, because we don't want to be in a position at a blood center of doing some sort of proportional rationing of blood products. We want to know that you're marshaling the blood supply very carefully, so we don't have to make decisions about who gets the last unit of O.
Mm-hmm, mm-hmm.
And every place, I have a template, and I think most blood centers have templates that they've distributed to their hospitals and said, tell us when you're going to consider stopping elective surgeries and other elective admissions. Mm-hmm. Tell us when the blood supply is at level X, how you're going to triage those units. And when it gets worse, what are you going to do? And those conversations are going on as we speak. And if they're not, they need to be. So if you're a collection facility and haven't leaned on your customer hospitals to show you what their plans are, you need to do that right away.
One thing that I have interacted with people on social media with recently, and I wanted to ask you this question, Louis, because I know you're certainly familiar with this, and I remember speaking with you about it or hearing you speak about it during the Ebola issues a few years ago, and that's convalescent plasma. People have talked about convalescent plasma on social media, certainly as a quote-unquote magic bullet, and you and I haven't talked about treatment options for COVID-19 today, and we're not going to again. That information is out there elsewhere. But convalescent plasma is something that blood banks might be involved in. So could I just get your quick perspective on if there are any discussions going on about that and what your general thoughts are?
Yeah, it's ongoing in China. And I'm not going to tell you who, but there are two groups in the U.S. that are working on coordinating clinical trials of convalescent plasma. Both the Red Cross and my old organization, America's Blood Centers, have been contacted, and the protocols are being written. The requirements for selecting donors and all the things that have to happen are happening, and certainly I'm going to do my best to facilitate it if it comes to fruition, that we're going to have ongoing clinical trials. The only note of caution that I would raise is there's some old animal studies of coronavirus vaccines where, in fact, pushing an immune response in the animals with vaccines made the illness worse. So it's not a panacea, and it needs to be studied very carefully in appropriately designed trials. And the groups that are working on it are really good at those sorts of considerations.
And Louis, just for the learners that are listening to this and I realize I didn't really say what convalescent plasma was, just the thumbnail. What actually is it?
Well, so obviously, if you get pneumococcal pneumonia or you get influenza or any of a wide variety of infections, you make an immune response. And part of that immune response is antibodies in your plasma. So the thought is, if I get somebody who's recovered from the infection, and wait until they're completely well, I take their plasma. It's got high levels of antibody. We give it to somebody who's sick. It will help. It is absolutely true for a very common disease that we've all seen many cases of, Argentine hemorrhagic fever. But in fact, there are maybe not controlled trials, but good evidence from 1918 that it might work. And old data on serum therapy from pneumococcal pneumonia and some other things that suggests that it might work. So there's a good biological rationale for trying it. And of course, when we give people with antibody deficiency intravenous immune globulin, that's what we're doing.
Yep.
So it's rational. It's difficult to do on the fly, and that's going to be the operational hurdles to getting up and running are not trivial.
Louis, as we close our time together, I'm wondering if you would just break out your crystal ball and, as best you can, again, given your background in infectious disease, I think it's based on the history of what we've seen in the past. There are certainly some predictions, at least, that can be made. Again, granted, it's March 15 and things can change dramatically in moments. But as of today, what do you see happening over the next week, the next 2 weeks, et cetera, in terms of cases, in terms of impact that we might see?
It's going to get worse before it gets better. The problem that I have is I have no idea the timeline or how much worse. There are modeling exercises that are already in print, not peer-reviewed, but in print, that suggest a third of the population will become infected. And if that's true with a 1% mortality rate, that's catastrophic. Those all assume that there are no interventions, and interventions have started and are expanding. So I think those worst case scenarios are incorrect. But I don't know how incorrect, and I think we all need to understand, we're in it together. Everybody has to cooperate and listen to what public health is saying, and we need to pay very close attention, literally on a day-to-day basis, in order to do the best we can do.
Absolutely.
This is about cooperation from the general population, and I think it's possible. But I'm as you know, an optimist.
Eternal optimist. That's how I've always described you. All right, Louis, thank you so much for doing this. I really appreciate your time. Maybe if necessary, we can check in later on down the line. But again, thank you so much for doing this today.
You're welcome. My pleasure.
Hi, it's Joe with just a couple of quick closing thoughts. My thanks, of course, to Dr. Katz for taking the time to do that with me. I think we all have many, many questions, and I hope that answered some of them for you. We're all very, very busy right now in blood banking world in the United States. For those of you that are in countries that are even harder hit than we are, such as those of you in Italy, boy, I would love to hear from you on what is going on for you right now. Just feel free to comment at bbguy.org/082. You can also find some references at bbguy.org/082, where you will find some links to different pages, including that Johns Hopkins dashboard that I mentioned to you at the beginning. There's a lot going on, as I said. And in fact, I wanted to share with you a quote from Dr. Pempe Young, who's the Chief Medical Officer for the American Red Cross Blood Services. And she mentioned to me earlier today in a quote that the Red Cross is being very aggressive in regard to creating partnerships with departments of health, our hospitals, the media, as well as building an internal infrastructure to address this crisis. And quite frankly, she's right. It's a new frontier, really, for all of us. There's a lot that we need to do. Again, please remember this interview was recorded on March 16, 2020. One thing about doing an interview on a topic like this is that we're almost guaranteed to be completely out of date in a few days. But I really wanted to get this out to you now. And again, give you a little bit of what we see as potentially some things to do, some things to think about. Again, please try and reassure your donors as best you can. We all know that that is not a zero risk proposition. There's no way that it is. But at the same time, as Dr. Katz said, in terms of relative safety, there is an argument to be made that being a blood donor is one of the safer things you can do right now. So thank you all for taking the time to listen to this podcast. As I say to you every time, and I think it's even more important right now, as you go through your day and as you go through this tough time, I hope that you still smile and have fun. Tell the people that you love that you do, and above all, never, ever stop learning. Thank you so much. We'll catch you next time on the Blood Bank Guy Essentials Podcast.